how do Medicare and Medicaid differ in terms of covering assisted living and similar long-term care facilities?
This is a really good question. So I talk about this a lot on my YouTube channel where I get really deep into Medicaid. And I think it's really important to understand the differences between Medicare and Medicaid because people confuse them. They sound the same, they feel like they're similar.
What's the rate difference from patient who does private pay versus the reimbursement from the Medicaid?
That's a good question. It's going to depend on the state. So I'm going to kind of try to paint a picture for you on how these things work. So private pay is very straightforward. You go, you collect directly from the resident, you set the rates and everything. Like you're in total control there. When you work in Medicaid, you have some ability to improve the rates that you have, but you also get paid in multiple ways.
Welcome to Senior Living Investment with Emily. Today I have a great pleasure to have Brandon Gustafson on the show. Brandon has over a decade of experience in healthcare industry and with expertise in assisted living and the Medicaid. He owns 2 assisted living facilities himself. And what amazing is he managed Medicaid billing for Optimum. He has all the experience that we would need to understand how we can get public patients for the assisted living facility. And in addition, Brandon has also taught healthcare analytics at University of Utah and served on the board of Utah chapter of Healthcare Information Management Systems Society. Welcome to the show, Brandon.
Awesome. Thanks, Emily. Excited to be here.
First, I would like to know, can you share your background and experience in senior living?
Yeah, so I got into senior living in 2020. So I've been in the healthcare industry for a long time. I graduated with my MHA from the University of Utah in 2015 and had worked for a bunch of companies, large healthcare payers. I had worked for nonprofits and had a lot of experience in healthcare. But as we got into the pandemic, I had switched jobs, went remote, was kind of getting bored, and I had gotten into real estate about a year previously. And when I found assisted living as an asset class, I was like, this is something that really aligns with my background in healthcare and my interest in getting into real estate. So I decided I'm going to figure it out. So prior to that, I had very limited experience. Had worked as a CNA when I was in high school, 20 years ago at a nursing home, and really enjoyed that. But the reason I got into healthcare administration was I never really wanted to be a provider. That wasn't something that's like doesn't really align with me. It's not something I wanted to do. But I love helping people and I love being part of the business there. So
Mhm.
that's kind of what turned me into assisted living. And we went through the process of buying an existing home and closed on that in September of 2020. And then bought a second one closed on that one in February of 2021. So it's been a few years.
What I learned from our prior conversation with your facilities, you mostly deal with public pay patients because you have tons of experience with Medicaid billing management. And today, actually, I want to focus on this Medicaid related questions. My second question for you would be, how do Medicare and Medicaid differ in terms of covering assisted living and similar long-term care facilities?
This is a really good question. So I talk about this a lot on my YouTube channel where I get really deep into Medicaid. And I think it's really important to understand the differences between Medicare and Medicaid because people confuse them. They sound the same, they feel like they're similar. So I'll give a kind of a quick overview of the difference between them and then get into how we use Medicaid in our facilities. So Medicare is a federal program. It's federally funded at a federal level. When you put in your taxes and things, when you look at your W-2 statement, it takes stuff out. One of those is for Medicare. It goes into a bucket for people when they retire and they're on Social Security and they can get Medicare. Medicare is typically going to be for individuals that are 65 plus. There's varying degrees at when you can start taking Medicare. Medicare is not something you can use in assisted living. If you go to a nursing home, however, you can use Medicare. So it's just kind of like a level of care type of a thing is what Medicare is. There's different parts. We don't need to get into all of Medicare, but there's a lot that goes into it, a lot of different programs. Medicaid, on the other hand, is also a federally funded program, but it's administered at a state level. So each state receives federal funds and they say, here's $1 trillion that you can use for your Medicaid stuff. And then the state will pass budgets at a state level and say, okay, we're going to allocate X amount of money over here and Y amount over to this section over here. Medicaid is something that you can use for assisted living. It is an approved expense. And so the way that it works is there's different codes with Medicaid. And just like you would see with typical billing in healthcare, there's a code for Medicaid assisted living, and it's just kind of an all-encompassing, you're here at the house and we're providing all the care that you need. There's not multiple codes, it's just one. They tell you what it is, they tell you what you can bill, and then you just bill that there. That's the simplified version. And the difference between Medicare and Medicaid and kind of how they work and how Medicaid actually works inside of assisted living for you if you want to go that route with your facility.
Basically, Medicare is mostly for skilled nursing homes, but Medicaid is the one that is the patient can use to pay for the assisted living, long-term care facilities.
Yeah, so when it comes to senior living, let's just use that as like our all-encompassing thing. When it comes to senior living, Medicare is for nursing homes, Medicaid is for assisted living. A resident could have Medicare and they can get their prescription benefits and things. There are benefits they can use with Medicare when they're in your facility, but you as a provider cannot bill Medicare for assisted living. That's not a thing that you can do at this point. Stuff could change. Who knows what rules they come up with? But as of today, 2024, Medicare is not a billable code for you as a provider for your resident.
I mean, are there different type of Medicaid that the patient needs to be qualified to pay for assisted living care?
No. So the way that a resident is going to qualify for Medicaid, there's a few different requirements. One is like an age requirement, similar to Medicare. One is an income requirement, and then there's like a disability type of requirement. So they could qualify for Medicaid in a variety of ways. The way that they do that, most states will have some kind of a portal where they can apply and receive Medicaid. And once they obtain the Medicaid benefit, now they can go to any provider that is certified for Medicaid and they can receive services from that person. One thing that you want to make sure that you note with Medicaid is it's not always one administrator per state. So it's administered at the state level, but that doesn't mean that there's just one provider for Medicaid. As an example, we operate in Colorado. There's just one. It's the state of Colorado. It's administered through Gainwell. They're kind of the group that does all the paperwork and stuff for it. In Idaho, however, where we have another facility, there are three administrators. So there's the state of Idaho, there's Molina Healthcare, and there's Blue Cross of Idaho. And all three of them, and a resident can get Medicaid through any of those three places. So as a provider, if I want to receive reimbursement from a resident who has Blue Cross of Idaho for their Medicaid, I need to be certified with Blue Cross of Idaho. So we certify with all of our Medicaid providers in the state, because if I don't, then if somebody has Molina and I'm not certified, I can bring them into my house, but I'm not going to get paid for it. So I want to make sure I'm certified with all the Medicaid providers.
Okay, so basically, from what I understand is not all the assisted living, they are certified to receive this government, like public pay patients. And then what's the process to get certified?
Yeah, good question. So you're correct. Not every single provider is going to be certified to deal with Medicaid residents. You have to go through a process and do that yourself. It's going to look very similar to the licensing process. So when you get licensed with the state to run your facility, there's an application, there's paperwork, there's insurance. You have to get all of this stuff, bank information, all of that. You have to hand it off to the state to get your facility license. Medicaid's going to look very similar. It's going to be a different department within the state. Oftentimes it's like health and welfare. It's going to have to do something with welfare. So that's who you're going to work with. But the process itself is very similar, maybe slightly more complex or more complicated just because you're dealing with a different government agency and they do things differently. And it's probably not quite as refined as getting your license, but you can still work through that. You gather all the paperwork, you work with them, you submit it, they get back to you and they say, yep, you're approved, or we need this other paperwork. The process itself is not complex. It's just making sure that you tick all their boxes, get everything, and then get the approvals, and then maintain that approval. Similar to like your license with facility license, you're going to have to do maybe some continuing education courses, make sure that you renew things on an annual basis and get things to them. Just have good communication skills is the way that you maintain that certification.
Right. And how long does it generally take for the facility to get certified?
In my experience, and each state's going to be different. In my experience, oh god, we've had some actually in Idaho where it was like a 4 to 6 week process and everything was
Mm.
done and it was good. We've had another administrator in Idaho and then in Colorado where it was like a 4 or 5 month process and it was very lengthy. And what that means for you as a provider is you can say, yep, we are a Medicaid provider, we can accept Medicaid residents. You can bring them in, but you're not going to get reimbursed from Medicaid until you receive that certification. You can back bill though, based off of when you start that application with them. So you can still bring residents in and work with them, provide them care and things like that. But there's going to be the gap between when you started the application and when they approve it that you're not getting paid from Medicaid. So that's something if you're 100% Medicaid and you don't have a lot of operational income or operational just capital to run the business, you might want to wait a little bit before you get started because it is entirely possible that you could be providing services to somebody for 4 months and not getting paid for the daily rate that you're able to bill Medicaid for that period. But then when you get it, all of a sudden now you have, $60,000 that drop into your pocket and then you're okay. So it's just kind of a waiting game and figuring out that process with people. This is part of why a lot of people don't like Medicaid because there's paperwork and complexities to it, and it's a game that some people just don't want to deal with, and that's totally fine. But it is a viable option to allow you to make money and be a profitable business.
Okay. And what's the acceptance rates, like generally speaking, for a provider to be certified for Medicaid?
That's a really good question. I don't know if I have a number off the top of my head. I would say it's pretty high though, because once you become licensed as a facility, which is part of the things you have to give to Medicaid to become certified, is here's my license for being a provider. Apart from that, like honestly, some of the biggest hiccups we had in Colorado, which took us 4 or 5 months to get certified, was documentation for our bank. And they wanted it in a certain format on a certain letterhead. And this, like, they had just requirements that I felt like were just stupid, that were really hard to kind of figure out there. And once we figured it out, it was fine. It's just getting them all the information. If you're already a licensed provider, the state getting certified for Medicaid is, I would say, your likelihood of getting it is in 99%. It's pretty high.
So the only caveat I would see here is basically the amount of time that may not be predictable in terms of get the license ready for the facility.
Yeah, that, and then just like you're dealing with government stuff, and so there will be delays. We have had instances with Blue Cross of Idaho, for example, who they shifted over their system to something new, and so it delayed payments for us for a couple of months. And they were trying to catch things up. They just went through a system update, and it didn't go as they had planned, so it caused delays. So like what you have to realize when you're doing this is you're dealing with government and it can take time and there's only so much you can do to really push them along.
Yeah. And what's the rate difference from patient who does private pay versus the reimbursement from the Medicaid?
That's a good question. It's going to depend on the state. So I'm going to kind of try to paint a picture for you on how these things work. So private pay is very straightforward. You go, you collect directly from the resident, you set the rates and everything. Like you're in total control there. When you work in Medicaid, you have some ability to improve the rates that you have, but you also get paid in multiple ways. So one way that you get paid is directly from the resident. You actually receive money from them like you would with private pay, and you're getting that money from their Social Security. So they get, let's say they get $1,000 in Social Security. The state will tell you you can collect, 85% of that $1,000. So you bill them $850, and that comes directly from them. So you get that money. The second part is going to be And we call that rough payment, which stands for rent, utilities, and food. Like that's what we call that piece. The next section is going to be your daily rate that you are billing to Medicaid.
Mm,
The daily rate can adjust based off of the level of care you're providing to your residents. So
mhm.
just as you would with private pay, where you track everything, your ADLs, and say, okay, we're doing more care, you owe us more money now. The same thing happens with Medicaid. It's just you're not talking to the resident themselves. You go through a documentation process. You can do this at least annually or when their care changes, like if there's a big change in their care plan. But you do the assessment, you provide that to the state and say, we're providing X amount of care. We feel like we should be getting paid more. And they could come back and say, nope, sorry, that doesn't work. Or they could say, yes, that's accurate. We're going to bump this up. So daily rates there, they can vary. Like I mentioned, they kind of get approved at the state level by legislature. So things can vary. Typically, what we'll see with like a low maintenance type of a resident that doesn't need a lot of care, their daily rates are going to be somewhere like $70, $80 a day is what they'll get. But if you provide more documentation that shows that you're providing more care, we have residents that are on Medicaid that are $140, $150 a day in Idaho. And we're not memory care. We're just a standard assisted living facility. We're just documenting all the work that we do, and we can get daily rates that are double what they were for us previously. There's actually a third way that you can get paid with Medicaid, and it's called share of cost. And what this is, they'll look at like a gap. So some people, they get maybe some extra income that comes in from an investment or a family member or whatever. To maintain their Medicaid status, they have to maintain like a certain amount of money in the bank for them. And if they go above that, they get kicked off of Medicaid. So if there's ever this spot where they're kind of in a gap, the resident themselves may end up having to pay you more than that 850, that rough payment, and they have to get into a share of cost and they're paying you an extra 100, 200. It's not the case with every single resident, but we've seen it several times. So you have the potential to actually get paid three ways. So, and to kind of go back to your question, the difference in Idaho, we do Medicaid. 90% of our residents are on Medicaid. We have residents that are between $4,500 and $5,000 a month, what we're getting for those Medicaid residents.
Is it comparable rates that compared to other facilities who mainly focus on private pay?
Yes, it can definitely be there. Like we could not compete with somebody that is. I know you talked to Brandon Schwab before, and he does like his boutique stuff, and he has like this really nice, high end stuff. People done in Arizona, people that private chefs, they're concierge, they're paying $10,000, $12,000 a month. I can't compete with that. Like that's not our model. But I can get between $4,000 and $5,000 a month per bed, and then we're doing shared rooms, and I could get into why we do that and how that works, and still making it a good spot for residents. But having $4,500 in a shared room, that's $9,000 for that bedroom. That's pretty dang close to that 10, 12,000 that somebody might get for a really nice high-end facility. And we're still providing really good care to our residents and respecting them because we know that they're people, right? They're not just a number for us. They're not just somebody. We don't want this to be a crappy situation for them. We want to make sure it's comfortable for them. We just kind of do it a different way, do it in a different model.
Just hearing what your response was, I have a few follow-up questions. First one is, throughout the period that you are waiting for to get approval to get the certificates, how can you manage that you get enough income to operate the facility? I mean, because in your case, you have 90% of the patient from Medicaid. How do you navigate that kind of situation for the 4 or 5 months? You still have enough money to operate the facility, or even you have to reserve more in case it takes even longer.
Yes, no, this is a really good question and something. When we bought our first house, I never even thought about this scenario. We struggled quite a bit when we did our first house. We bought an existing facility, mostly Medicaid. We had to go through the process to get certified, and then we didn't get paid for the most part. We got that rough payment, that $900 per resident per month coming in, but when you're trying to run a house and pay everybody's wages and things like that, like that money dried up super fast. So What we learned from the first one, and we've then applied this to the second one, is in the purchasing process, we asked for more operating capital up front to get more money in the bank so that we could have that money to handle those expenses while we were waiting on Medicaid to get set. And because we had the two facilities, we were able to kind of draw from the one facility to help out with payroll and then just pay it back once we got that big chunk of money at the back end. So that's a really good strategy for doing that. Now, if you don't have the capability to do that, maybe you own a facility, you're already operating it, and it's too late for you to get that extra operating capital, you could look at doing small business loans. You could look at doing some kind of like a line of credit or something like that, because that money, it's going to come. So if you just need something to help supplement you while you get things in place, there are other options there that you could consider. But I would suggest, very highly suggest, that you have a good chunk of money set aside so that if it does take you 4 or 5 months, you can weather that storm and then pay yourself back. That's the best way I could tell you to do it. But we learned from that first scenario and applied it to the second one, and it helped out a ton. Let us breathe a little bit, which was good.
That's great. And if I understand correctly, once a facility gets certified, in some of the states, say Wisconsin, they have a long wait list of patients who are qualified for Medicaid and they want to get into assisted living facility. In that case, you will not have a shortage of patients coming to your facility, correct?
Yeah, the bigger problem is making sure that you get good ones, honestly. And so there's maybe a higher level of vetting that goes into it. Because if you're a private pay and you're somebody's paying you $10,000 a month, you know, they might be a jerk. They might be really nice as well, but you're dealing with a very different set of person than I am with my house. What we want to deal with inside of our homes is we want somebody that isn't going to disrupt things. So when we have open beds, we go through a very in-depth process that is kind of more centered around like the person themselves and are they going to be a good fit culturally for us, because there are so many people that are out there that need Medicaid beds, and so we want to make sure we're providing really good service to those people, but it's also not going to rock the boat. And when somebody comes in and they are disruptive, we are pretty quick to act to ask them to leave, and we write that into our resident agreements so that if they are doing things they shouldn't be doing, being disruptive and disrupting the culture of the home, they don't last long with us because we know we can
Okay.
find somebody else to come into the house pretty quick.
And when a patient comes into your facility, does it come with already the defined tier of level of care? Like say if it's level tier one, tier two, or tier three?
Yeah, they'll have like a level that they come in at, but just like you would with a private pay resident, we have our nurse go and do an assessment on them, confirm that we're being told that they are is accurate, that we can handle them, that the care that we are able to provide in our home aligns with the care that they need. So we're doing that level of vetting as well and making sure that they're a good fit for us from a care standpoint and that we can provide that care for them. But yeah, they kind of come in with just like a level that says, yep, this person's level one type of care. We do the assessment, make sure it's accurate, make sure they're a good fit, and then if it is, then we bring them into the house.
That's very interesting. And the other question for you is, since you mentioned the amount of paperwork that is needed to get this Medicaid patient, does it mean that you need to have more staff member in your facility? And how does it going to balance in terms of the quality of care that you can provide to the patient, plus basically your investments?
Yeah, no, those are all really good questions. So to start off with, from a staffing perspective, there's no difference there. I mean, we still adhere to the resident to caregiver ratios that are outlined in the state. So if it's, 1 to 10 and we have 16 residents, and we're going to make sure we have the staffing to meet that need. So we just kind of follow those guidelines that the state has given us to make sure that we have proper staffing to care for the residents to meet their need is really what it is. Typically for us, because we're a smaller residential facility, if it's a two-person lift, we probably aren't going to have them in our house just because we're not going to have the staff to handle that. So that's like kind of a level of, I don't know, criteria for us that we want to take into consideration for us. That's not broad for everybody else. But yeah, so you're not paying more for staff. We handle a lot of the billing ourselves. The billing process is not all that complicated, especially after you learn it. It becomes very simple to do. Different states have different portals. It's a relatively simple process to bill and collect the money. The revenue coming in is pretty consistent. Actually, what's kind of nice about it is you can bill Medicaid as frequently as you want. They pay out on a
Hmm.
weekly basis. So you could
Mhm.
essentially get income coming in on a weekly basis. And that can really help when it comes to payroll and things like that. If you are like, crap, I'm $4,000 short on payroll this month, you could bill Medicaid and get reimbursed for it. And now you've got that chunk of money to at least make payroll. So that has been actually a really big blessing for us to have that in place. Has helped us get out of a bind a couple of times. So that's really helpful in getting there. And then yeah, like just from a profitability standpoint, from a business, we're doing fine with our homes and the way that we do Medicaid, and it works really well for us. And we're able to generate sufficient income that like we're happy with it enough that I believe in the model that we're going to expand. That kind of stuff. Like it is not something that I'm like, this was the worst decision I ever made. Not at all. We feel very confident in what we're doing and the niche that we're in and how we're building things.
Mhm. I also want to know, why do you choose this niche, like 90% of the patient being Medicaid patient rather than doing something more private pay oriented?
I think for me, one of the reasons, and this wasn't like intentional for me, but I have a lot of experience in government programs and in this world of working with this. So I'm familiar with it. And something that I can like foresee on the horizon is you've got big box places that will probably be Medicaid, and you're going to have the really high end, nice boutique style homes that people will pay a premium for. And so you're going to kind of have this, and we're a little bit in the gap where we're still that residential style and still have that more family feel, and it doesn't feel like an apartment building, but we can get the best Medicaid residents out of it because maybe they don't want to go to one of those big apartment style homes and they want something that feels a little bit more friendly. And we're setting ourselves up to kind of be in that gap. And I feel like that's going to benefit us quite a bit as we go through this and allow us to keep occupancy rates really high. And now that we've figured out how to do Medicaid and we're not scared of it and can handle it, it's just like I think we've got a really good population that we can work with and make sure we have our beds full and we've got really good cash flow for the business.
And how does the staffing change based on the level of care needed by your residents?
Similar to what you'd see in a private pay, you would do your assessments and make sure that you have sufficient staff to provide that to the resident. It's going to be outlined in their care plan. So there's really no difference between a private pay and a Medicaid resident. There's no like extra requirement with Medicaid that says you have to have 2 or 3 staff in your home at all times. Like there's no rule there. Now, let's caveat that and say this is government. Who knows what they're going to say? So they could change stuff eventually, but I really don't foresee that as something that will come up. And if they did, it would be industry wide, not just Medicaid. So I think we're in a pretty good spot there, and I feel like we're protected from anything like that happening.
But then if you get level 1 and 2, would you get a lot of like homeless patients to your facility?
Yeah, we've never had that problem. I mean, the home that we have in Colorado is a mental health facility, and just the area deals with a homeless population. So we do there, but that's I would say largely because that's the type of resident that is going to come into that home anyways. And so that's a completely different story. But in Idaho, where we do kind of senior care type of stuff, it has never been a problem for us bringing in the homeless. We have had one resident that came in that was previously homeless, but she's like one of our best residents. So she's great. She just like fell on some really hard times for a period of a month or two, and she's been great for us. So it kind of goes into that vetting process up front and making sure they're a good fit, and then as well as having really good policies in place that if something happens that they're no longer a good fit, that you're discharging them to get them out of the house.
How do you vet a patient?
Yes. So our nurse is going out, doing assessments with them, making sure that level of care is going to align with what we can provide. Our administrator is going out and talking with them, getting to know their family a little bit better, case managers, all those people that kind of know this person, getting a holistic view there. And then we bring them into the home for tours as well, just so that they can get a feel and we can kind of watch them and see, how are they interacting with residents? Are they standoffish? When they come into the home, are the residents like, oh, they shrink away? Those types of things. We want to just kind of get a view of what's happening because that's going to allow us to feel comfortable. And if it's not, then, you just, oh, sorry, we filled the bed with somebody else, or you just kind of make up some kind of a reason that says why you can't bring them into the house. But yeah, that's kind of the process we go through to vet new residents.
You own two assisted living facilities. What are the most valuable lessons that you have learned from running these facilities?
I would say, because we bought existing facilities. So one of the things that I learned very early on was what I had just shared about, like getting that operating capital. So if you are buying an existing facility and your capital is going into the purchase as a down payment, it is very important for you, and you feel like you need some extra operating capital, build that into the conversation with the lender very early on. They are super comfortable with it. Most of them won't bat an eye at you, but doing that is going to save you a lot of headaches getting into it. So that's number one. Number two, we have learned, especially from experiences with our facility in Colorado, that the vetting process of bringing in the right resident is extremely important. Because in that home we have dealt with mental health things where somebody does not follow their medications, they can spiral very quickly. We've had some very unique situations, I'll say. And so we've learned a lot about bringing in the right resident to build the right culture, especially, working with the Medicaid population. There's, I don't know, crapshoot kind of a feel to it. But if you are good at evaluating individuals and bringing them in, you can maintain the culture and keep things the way that you want to do it. So I would say that those are two big lessons, one at the very front, and then the other one is just kind of as an operational thing is getting good people in there. And I think that goes through with like your staff and everything. You want to make sure you have good people that just kind of makes it feel like a family.
Yes, yes, of course. Speaking of, then I'm very curious with your first facility, you probably inherit a lot of patients from that first facility. Does it comes into a big factor in terms of the model that you are niching in right now?
Yeah, that it had a pretty big impact on us. So both of the facilities we bought ended up being Medicaid. And like as we were going through the purchase process, I became aware that that was the case. And because of my background in government programs, it was something I was like, oh yeah, we can figure this out. I'm not that concerned with it. And we were able to figure that out and work through it. But I've learned a ton through that process and how it actually works and how to take advantage of some of those things, like that weekly billing you can do it with Medicaid. Like, is a really good tip to allow you to get consistent cash flow in the business. And then just understanding how to work with case managers and raise rates as well. Like, this was something that we didn't realize we could do until a year and a half into it, that we could do assessments and demonstrate that we are providing more care for residents and we need rates increased. And that helped us out a ton as well. So there were things that when we got into it, like I was like, oh yeah, we can figure this out. Like, it's not going to be that hard, to where we are today, where we've learned a ton of lessons on how to take advantage. Sounds bad, but just kind of learn how to take advantage of some of those programs and leverage them in a way that is going to benefit us more as a business.
I also know that you have a 12-week program to help investor to gain access to assisted living ownership, to really share all the experience and lessons that you have learned from owning these two facilities. Would you mind sharing with us more about this program? And if you have any client success stories that you can share?
Yeah, for sure. Thank you. Yeah, so I have on my website my accelerator course, and it's a 12-week program because there's 12 modules in there. If you go through one per week, you're going to be able to get a really good head start in launching that business in 12 weeks. So that's at assistedlivinginvesting.net/ALA for Assisted Living Accelerator. And if you feel like you need some extra coaching and things like that, I have a mastermind program that takes that 12-week program and adds a bunch of stuff onto it. So that's at assistedlivinginvesting.net/mastermind. You can find all those on the website. So I love coaching people. Prior to owning the facilities, actually, as Emily had mentioned, taught at the University of Utah. I ran an internship program at one of my previous jobs. I have been a mentor for people that have gone through the MHA program at the University of Utah. Like I love getting in and coaching with people and helping them along the way. Because that's why I kind of developed this program, why I do that. And I've been able to help quite a few people. I've had 2 or 3 people reach out to me on my Facebook group that say, like, I followed your stuff and was able to open this facility, like without me really interacting with them because of the content that I just put out there, and have helped 2 people up in Idaho get things ready to go as well, to the point that they're just about ready to launch. And I'm super excited to see their progress. So it's really fun and rewarding to get in and coach people and kind of help them through that process and learn from somebody that has made a lot of mistakes so you don't have to make them yourself.
So I'm also curious, with these students of yours who have successfully launched their own facilities, do they mostly have like the healthcare background?
They've got healthcare background, but they're not necessarily doing a Medicaid facility even. So, I teach a lot of those things because I have experience in it. But just because that's the model that I do, doesn't mean that you have to do it that way. So, like when I talk to people and coach them and things like that, I'll tell you all the stuff. Like I will be very transparent with you, the good, the bad, the ugly, all of those things, and give you the information so you can decide. And then I kind of help you through the process and learn what an application process is going to look like and how you're going to maintain that. Or if you want to go through a different route, how we're going to get funding and how we're going to talk with maybe some funding partners and things like that to help you learn what you need so that you can be successful as you're going in through that process.
That's very good. When you are looking for existing facilities to acquire, what are the important factors that you would take into account?
So I would say I want to look at bed counts for sure. And for especially going the Medicaid route, having something that's tiny, like less than 10 beds, really starts to shrink your margin and makes me start to feel uncomfortable. Like I personally, I don't think I would go for something that's less than 10 beds. So that's one criteria for me for sure. Number two is going to be just like the market research and making sure that I'm comfortable with the area. So some background on why that's important for me is our first one, it's in Colorado Springs. I love going to Colorado. Like it's beautiful. I love going there, but I probably rushed into it a little bit more than I should have. I ran the numbers. They were good. We felt comfortable with it. We went and did it. The second time though, I spent more time doing market research, figuring out, just looking at overall industry trends and where we wanted to be. And we went to Idaho, and it's been 9-day difference. And when we love Idaho, that's where we're going to grow our portfolio. And so taking the time to do that market research and make sure you're comfortable with your decision. Just because I'm, not focusing on Colorado going forward doesn't mean that's not the best spot for you. It could be, but you want to make sure you do that market research and feel comfortable in the size of a facility, geographic location, some of the trends that are coming through, the government that you're going to have to go in and handle, just like the politics of everything that goes into that, regulations that are involved there. Those are really important things as you're trying to make that decision. And then the third thing is just like building relationships with people that you can help, that can help you get what you want. That could be a broker, it could be a lender, it could be an insurance broker, like it could be any number of people, and you want to build relationships with all of them, but build good, solid foundational relationships that are going to benefit you now, but also, in the future when you're trying to get multiple facilities and grow your portfolio. Spend
Mhm.
time to build good relationships now.
In terms of market research, what kind of market research then one need to do to conduct to see if it's going to be a good fit?
Yeah, so actually on my website, I have a course that's called the Business Planning Guide. And in there, I have a module that's all about market research. So if you want to go check that out, it's assistedlivinginvesting.net/BPG for Business Planning Guide. And what I look at there is I want to look at, some of the demographics. Where are people moving to retire? Where are some of the trends that's happening? I want to look at politics, like I mentioned, just so that I know how they are leaning politically, because I know in a more liberal state, it's probably going to be more regulated, more heavily regulated. In a more conservative state, not as much. However, in a more regulated state, you might get higher reimbursement rates. So it's, the trade-off. You just kind of want to look at that. I want to look at crime rates. I want to look at what are some of the other criteria I have on there. How much people are making. You also want to realize that your population that you want to identify all this for is not the residents themselves, but the children of those residents, because they're going to retire somewhere. Their parents are the ones that are coming to your house, but they'll probably just bring them with them and put them in the house so they're close to where they're going. So these are some of the things that I like to look at when I'm looking at trends and doing my market research. And the way that I do that is I kind of narrow it down to, I'll kind of list it out to my top 10 states or so. And then with those, I narrow it down to some of the more micro markets inside of those states, but then give you the tools and the education on how I identified those. So that if you're like, I really like state number 15, and he didn't do the research on those micro markets there, gives you the background on how you can go and research all of that and all the resources so you can figure out which specific spot's going to work best for you.
This is amazing. All the audience who are interested in buying assisted living facility, you should all go to Brandon's website and to learn all in the ins and outs. And I also know that he give a free underwriting spreadsheets on his website. It's
Yeah, so we have
amazing resource there.
Yeah, and thanks. Yeah, so I've got the free underwriting calculator there. And if you dig or if you watch one of my videos, I have like 5 or 6 other things. So just like go, I have a bunch of free stuff for you to get to kind of help you out and get you started.
Thank you, Brandon. Yeah, I really appreciate that you spend the time with us today. And I look forward to bringing you on again to talk about underwriting, how we can underwrite an assisted living facility.
Yes, super excited to do that. It'll be fun.
Thank you.